Well, hello. So today we're going to have a little bit of a think about growth hormone and specifically how it functions in regulating growth, metabolism, and what happens in disease states where you may have a little bit too much or a little bit too little. Now, growth hormone is often thought of as simply just a growth promoting hormone, but in adults, its actual major physiological role is in regulating metabolism. So today, like I said, we are going to look at how GH or growth hormone is regulated, how it affects metabolism and growth, and what happens in excess or deficiency. So first, we're going to look at the normal physiology before considering disease. And understanding normal, healthy regulation of growth hormone secretion and synthesis makes it much easier to understand gigantism or acromegaly, where there's an excess of growth hormone or growth hormone deficiencies. So we'll just quickly have a bit of a review. This is nice and easy, thinking about the anterior pituitary itself, but how is the anterior actually regulated? Well, it's regulated by hormones that are released from the hypothalamus, and different hypothalamic hormones regulate different pituitary types. And the hypothalamus is integrating multiple neural, metabolic, hormonal signals before altering pituitary hormone release. Now, for growth hormone, of course, the major stimulatory hormone is growth hormone releasing hormone, or GHRH. There are other hormones involved. So, for example, somatostatin inhibits growth hormone secretion, but I'm not going to talk about that anymore today. So, like I said, what we're going to be talking about is growth hormone, which is released from the anterior pituitary, stimulated by growth hormone releasing hormone from the hypothalamus. So growth is a multifactorial process, and growth hormone itself is only one contributor. And growth is not just about getting heavier. From birth to about 2 years old, so during infancy, nutrition is particularly important during growth. As childhood progresses, growth hormone becomes a major determinant of growth velocity. But of course, thyroid hormone and nutrition are also very, very important. When you hit puberty, you've got your growth hormone, your IGF-1, which is your insulin-like growth factor 1, which growth hormone stimulates the release of from the liver. You've got your sex steroids. They all start to interact to produce the pubertal growth spurt. And other hormonal disorders can also impair growth, even if someone has normal growth hormones levels. For example, hypothyroidism, so a lack of thyroid hormone, that reduces growth. Excess glucocorticoids, so too much cortisol, suppresses growth. And poorly controlled insulin deficiency also impairs growth. It's also just to have in your mind that growth hormone is not the major regulator of fetal growth. Fetal growth depends largely on nutrition and insulin-related pathways rather than growth hormone itself. So, how is growth hormone actually released? What is stimulating? What is driving it? Well, there are lots of stimuli for growth hormone release. So you've got stress, you've got exercise, fasting, sleep, low blood sugar, amino acids, and the sex steroids. They are all drivers that are feeding into the hypothalamus, talking with the hypothalamus, and the hypothalamus integrates that information to release growth hormone releasing hormone. Growth hormone releasing hormone passes down blood vessels, so portal blood vessels to the anterior pituitary, where it drives pulsatile rather than continuous growth hormone secretion. And that growth hormone has metabolic effects. So growth hormone acts on growth hormone receptors to have metabolic effects. And we'll talk about that in a second. Growth hormone also acts on the liver, and in the liver, it stimulates the release of insulin-like growth factor 1, and that has growth effects on many, many tissues. Again, we'll talk about some of those effects shortly. But just like all endocrine systems, we have to control the amount of growth hormone and the amount of insulin-like growth factor 1 we're producing relative to the stimuli that are coming in. So there are negative feedback loops. And the IGF-1 is inhibiting at the level of the pituitary and the hypothalamus to inhibit both growth hormone and growth hormone releasing hormone from being released. And likewise, growth hormone inhibits at the level of the hypothalamus to inhibit the release of growth hormone releasing hormone. So let's have a think about some of the direct metabolic effects or actions of growth hormone. So this is growth hormone that is being released from the anterior pituitary, and it has mainly metabolic effects, as I talked about a second ago. And growth hormone is actually often described as an anti-insulin hormone. So it's kind of doing a lot of the opposite things to insulin itself. And in that case, you've got to think during fasting and during stress, the body must preserve blood glucose concentrations. And growth hormone helps to achieve this. And it does it in the muscle by reducing glucose uptake. So it reduces the amount of glucose taken up into that muscle. So it's sparing it for those other tissues. But it does stimulate amino acid uptake and stimulates protein synthesis. So it does drive an increase in muscle mass. It also acts on our adipose tissue. And again, on adipose tissue, it decreases glucose uptake, again, allowing glucose or more glucose to be spared for the rest of the body. But it also increases lipolysis, so it makes more free fatty acids available to the body to use as an energy store. And in doing both of these things, it's decreasing the fat deposits. So lean mass, lean body mass starts to increase. And in the liver, it stimulates glucose production and it stimulates IGF-1 production. So again, it's sparing glucose, or it's making more glucose to pass around to the rest of the body. So it's stimulating gluconeogenesis. And like I said, it's also stimulating IGF-1 production. So like I said, growth hormone in that respect is anti-insulin in its metabolic nature. It helps to preserve blood glucose during fasting or during stressful periods. And these effects help to explain why chronic growth hormone excess also predisposes to insulin resistance and to diabetes. So excess growth hormone can causes insulin resistance, and like I said, makes you more prone to diabetes mellitus. So in contrast to what we just talked about with growth hormone, what we're thinking about now is IGF-1, so insulin-like growth factor 1. And that's all about turning the growth hormone signal into growth itself. So many growth promoting actions of growth hormone occur through IGF-1. And remember, IGF-1 has been synthesized in the liver and released into the blood. And there it starts to act on skeletal growth. And it does this so in growing children, IGF-1 promotes expansion of the cartilage within the growth plates. So that is what allows linear bone growth, so the bones to get longer. After growth plate closure, further increases in growth hormone and IGF-1 cause the tissue to enlargement and bone thickening, rather than that increased lengthening of that linear bone, because they no longer are allowed or are capable of being linearly expanded, because you close the growth plates off. And that is a key distinction in trying to distinguish or understand the difference between gigantism and acromegaly, two conditions, both of which have an excess in growth hormone, but are happening before and after closure of the growth plate. As well as the skeletal growth aspects, it's also involved in soft tissue growth. So it stimulates protein synthesis. Remember, amino acid uptake, protein synthesis, cell proliferation, so hyperplasia and hypertrophy, and also tissue growth as a whole. So you can see it's working on skeletal growth and soft tissue growth. So we now know that growth hormone and IGF-1 are driving these two processes. And growth hormone secretion changes according to its own physiological needs, so how much is required. So there are lots of processes that are driving or talking to the hypothalamus, and the hypothalamus is then going to go on and release growth hormone, releasing hormone. So what is coming in? What is driving this whole process? Well, fasting and hypoglycemia are part of this pathway. And by doing so, the growth hormone is metabolically helping to maintain glucose availability for that hypoglycemia. You've got sleep. Sleep is associated with major growth hormone pulses. And remember, it's secreted in a pulsatile way. So it's secreted pulsatile. So when you are trying to measure it in a clinical situation, it may look normal, even though it's not, or vice versa, because you don't know whether you're in a pulsatile period or in the period where it's not pulsing or releasing growth hormone. Exercise and stress, of course, these are also associated with growth hormone release because they support fuel mobilization. And finally, as we've already said, puberty and the sex steroids, those sex steroids amplify growth hormone secretion and help contributing to the rapid increase in growth velocity that is seen during puberty and that growth spurt. And so all of those things are talking together, communicating. The hypothalamus is integrating all of that information to release the correct amount of growth hormone releasing hormone so that the correct amount of growth hormone and by extension insulin-like growth factor are both being released. So what I'd like you to do now, we've got a little review question. What have you picked up from what I've just covered in the last 10 minutes? So read this question and pick the most appropriate answer, and only one is correct. 17-year-old male is referred to the endocrine clinic because of unusually rapid growth over the last 2 years. Which physiological change would be most consistent with excess growth hormone secretion? Is it A, B, C, or D? Hopefully you have put C, increased lipolysis in adipose tissue, because remember, growth hormone stimulates lipolysis. And remember the other things that growth hormone is doing? It's increasing hepatic glucose production, so hepatic gluconeogenesis. It's reducing glucose uptake by both muscle and adipose tissue. It's stimulating IGF-1 production, and it's increasing amino acid uptake and protein synthesis in your muscles. So all of the others were wrong. So we're going to have a little bit of think about growth abnormalities now. What happens when things go wrong? So we're moving from normal physiology into pathophysiology. And your growth hormone disorders can be divided into either an excess or a deficiency. So if you've got too much growth hormone, you're thinking about the conditions gigantism or acromegaly. If you're thinking about too little growth hormone, it'll be impaired growth in children, and it's mainly metabolic effects in adults. So when you're looking at this, the key thing is the timing of the excess or deficient growth hormone. If there's an excess of growth hormone before growth plate closure, we see gigantism. If we see excess growth hormone after growth plate closure, we see acromegaly. And the signs and symptoms are quite different in both cases. So first, we're going to think about gigantism. And this is results from growth hormone excess before epiphyseal growth plate fusion, so the closure of the growth plates. The most common cause is a growth hormone secreting pituitary adenoma, and that increased growth hormone leads to an excessive growth hormone, leads to excessive insulin-like growth factor, which means you get an acceleration in your longitudinal, so the lengthening of bone growth, and a marked increase in height. But body proportions are usually fairly well preserved. So, and this because you've also got the soft tissue growth is also happening. How is it diagnosed? I'd like you to just press pause and have a little bit of a think. You don't need to know the answer. This is thinking. What have we just covered? What do you think might be done, thinking about hormones in particular? What hormones might we measure to see if someone has gigantism? Press pause, have a think. So I want you to think about hormones first. So the preferred screening test is actually looking at IGF-1 levels, and an elevated IGF-1 is an indication that someone might have gigantism. And so then you would do a suppression test, and a suppression test is used when you have too much of something and you kind of go, right, I want to try and suppress it. I want to try and reduce it. Is it reducing as it is meant to if the physiology, if the endocrine negative feedback loops are working correctly? So what you do is you give an oral glucose tolerance test. So you provide someone with glucose, and that would normally suppress growth hormone because there's lots of glucose, you don't need the growth hormone to be released. So normal individuals suppress growth hormone, whereas patients with excess growth hormone fail to suppress that growth hormone. So that's your kind of test to distinguish what's happening there. But a key question is, we've just said the hormones, we're doing a suppression test and we're looking at IGF-1, But why aren't we looking at growth hormone? Have a little bit of a think about it. You should know this. We have talked about it. Have a little think. So why aren't we measuring growth hormone? Well, it's important to remember that growth hormone secretion is pulsatile. So a single growth hormone measurement may be normal even in a patient with disease. So what else can we do as well as hormones? Well, you might do imaging. So you might use a pituitary MRI to identify a potential adenoma. So that's just using magnetic resonance imaging of the pituitary to look for an adenoma. So now we're going to have a little bit of a think about growth hormone excess and acromegaly. And this is after growth plate closure. So that's when we have acromegaly. And in this case, just like in gigantism, it's usually caused by a growth hormone secreting adenoma. But in this case, since the height can no longer increase, that excess growth hormone and the excess insulin-like growth factor causes enlargement of the soft tissues and thickening of the bones. And some of those classic characteristic findings, as you can see in the image to your right, includes enlarged hands and feet, coarsening of the facial features, widening of tooth spaces. So there's some clear signs and symptoms that you can see. Patients may also develop headaches and visual disturbances because of tumor compressions within the pituitary gland itself, impacting other structures within that area. The same biochemical tests are used, so I won't go through those in detail. So you'll look at elevated IGF-1, you'll look at growth hormone, the oral glucose tolerance test, and looking at growth hormone suppression, and imaging through a pituitary MRI. And complications, as we kind of touched on a little bit earlier in adulthood, can lead to diabetes and insulin resistance, can lead to hypertension, can lead to cardiomyopathy, where the size of the heart increases, and sleep apnea because of an increase in the soft tissue, making breathing at night particularly difficult. So we've done growth hormone excess. Now we're going to have a little look at growth hormone deficiency. And you have different effects at different ages. And in children, the reduced growth velocity often leads to short stature, but body proportions remain normal because all growth processes are affected proportionally. So there'll be delayed bone age, there'll be increased fat mass, reduced muscle development, but like I said, those body proportions remain normal. In adults, the clinical picture is more subtle. Patients may develop a wide range of other symptoms. So they may get that increased fat mass, but especially centrally, so around the tummy region. They get a reduction in lean mass and a reduction in bone density. They have a reduced exercise capacity, because thinking about what growth hormone does in terms of metabolic effects. And it can also lead to an adverse lipid profile. So thinking about your LDL cholesterol, your total cholesterol, your HDL cholesterol, and triglyceride levels. So you get an adverse lipid profile. How is it diagnosed? Well, its diagnosis is more difficult than diagnosing growth hormone excess. So a low IGF-1 may suggest growth hormone deficiency. And in this case, instead of doing a suppression test, you do a stimulation test. So you do a dynamic stimulation test. And that is where growth hormone would fail to rise with stimulation. So in this case, you drive hypoglycemia by giving insulin, and you would expect growth hormone to rise, but the growth hormone doesn't rise in someone with growth hormone deficiency. And again, an MRI may help to identify pituitary pathology causing a deficiency. So something a little bit different now. Okay, so recombinant human growth hormone is actually an important treatment for confirmed growth hormone deficiency. So it's used as therapy, but there is misuse and there are myths. So what are its legitimate uses? Well, like I said, confirmed growth hormone deficiency and specific pediatric growth disorders. But there are misuse claims in inverted commas as well, because outside medicine, growth hormone has gained a lot of attention as an anti-aging or a performance-enhancing drug. So there's no doubt at all that growth hormone may alter body composition, such as muscle gain and fat loss. And Sometimes people say, oh, it's enhancing performance, but actually evidence for improvements in strength or physical performance is very, very weak. That doesn't mean you don't gain muscle, but it's not the strength-based muscle. And you do get fat loss, so you do become leaner. But of course, there are consequences to that. So excessive growth hormone administration can cause swelling, so edema. It can lead to joint pain, insulin resistance, and diabetes. And because of the growth of your tissues, it can lead to carpal tunnel syndrome or carpal tunnel-like syndrome symptoms. And in essence, it isn't a substitute for exercise and nutrition, because nutrition and exercise are far more important for healthy aging than growth hormone supplementation. So finally, what I'd like you to do is have a read of this final little review question. Look at the answers. I will give you a clue that more than one may be correct. So press pause, have a read, then we will go through it. A 45-year-old patient with enlarged hands and feet, coarser facial features, new diabetes, and a pituitary mass. Which features are explained by growth hormone excess in this patient? So, A, true or false? Insulin resistance or diabetes? Yes, growth hormone does drive insulin resistance and can lead to diabetes, and this patient is newly diabetic. B, increased adult height. That is not correct. Remember, the long bones have already fused, so therefore you don't get an increase in height in acromegaly, which is what this condition is. Thickening of the fingers. Yes, that is correct. You get growth widening of the bones. Enlarged jaw and dental spacing, that is also correct. And soft tissue enlargement, that is also correct. So remember, a key difference here is you don't get an increase in height in acromegaly, but you do in gigantism. Thank you very much.